If you're over 70, there are medical tests that may actually do more harm than good, even though they're still routinely ordered every day. And no one tells you this because the system isn't designed to slow down. It's designed to keep testing. Today, I'm not telling you to avoid doctors. I'm not telling you to ignore symptoms. I'm going to show you 5 very common medical tests that often stop making sense after 70, based on evidence, not opinions. If you or someone you love is aging, this information could protect your health, your independence, and your peace of mind. And I'll also show you exactly when these tests do make sense, so you're not guessing, you're choosing. Screening only works when you live long enough to benefit from the treatment. This is called lead time, and it changes everything after 70. Many diseases grow slowly. Many treatments carry immediate risks. When those timelines collide, testing can reduce quality of life instead of protecting it. Colonoscopy has saved countless lives. There is no question about that. For decades, it has been one of the most powerful tools we've had to prevent colon cancer, catching dangerous growths before they turn deadly. When used at the right time, in the right population, it is a medical success story. But medicine is not static. As our bodies age, the math changes. What was once a clear benefit can slowly shift toward uncertainty and eventually toward harm. And nowhere is this more important to understand than in colon cancer screening after the age of 75. Colon cancer does not happen overnight. In most cases, it begins as a small, slow-growing polyp that may take 10 to 15 years, or even longer, to become dangerous. That long timeline is exactly why colonoscopy works so well in younger adults. You have enough years ahead for removing a risky polyp to actually matter. But after 75, time itself becomes a critical variable. Because while cancer risk grows slowly, the risks of colonoscopy rise every single year. The preparation alone can be physically taxing. The bowel prep causes significant fluid loss, which increases the risk of dehydration, kidney injury, and dangerous electrolyte imbalances, especially in older adults who may already have fragile kidneys or heart disease. The frequent trips to the bathroom raise the risk of falls, particularly at night, when balance is worse and reaction times are slower. For some seniors, the prep is not just uncomfortable, it's genuinely hazardous. Then there's sedation. Older bodies process medications differently. Sedatives can linger longer, increasing the risk of confusion, breathing problems, aspiration, and prolonged recovery. What might be a routine nap for a 50-year-old can become delirium or respiratory distress for someone in their late 70s or 80s. And although rare, the most serious complication, bowel perforation, becomes more likely with age. A perforation can turn a screening test into an emergency surgery, prolonged hospitalization, or worse. Here's the part that often gets left out of the conversation. If you've had regular, normal colonoscopies earlier in life, the likelihood that a new polyp found after 75 will ever harm you is very small. Many of these late-life polyps grow so slowly that they would never become cancer during your lifetime. Finding and removing them may look proactive, but in reality, it may offer no meaningful benefit, only risk. This is not about denying care. It's about matching care to reality. That's why the U.S. Preventive Services Task Force recommends individualized decision-making after age 75 and stopping routine screening altogether after 85. Not because screening suddenly becomes bad, but because the balance between benefit and harm shifts. Medicine should never be one-size-fits-all, especially as we age. Yet many people continue getting colonoscopies simply because that's what we've always done. Some are never told that stopping is an option. Others fear that saying no means giving up on their health. But choosing not to screen is not the same as choosing neglect. In many cases, it's choosing wisdom. It's recognizing that the goal of healthcare is not to find every possible abnormality, but to improve quality of life, preserve independence, and avoid unnecessary harm. This decision should be personal. It should consider overall health, past screening results, life expectancy, and personal values. A healthy 76-year-old with no prior screenings may benefit. An 82-year-old with multiple normal exams and chronic illness may not. The key is conversation, not automatic scheduling. So if you or someone you love is facing this decision, ask the deeper question. Not just, can we do this test, but will this test truly help me? Because the most advanced medicine isn't always about doing more. Sometimes, it's about knowing when enough is enough. And here's the truth most people never hear. The bravest medical decision isn't always saying yes to another procedure. It's having the courage to ask whether it still serves your life. For decades, mammograms have been framed as a universal good. Simple, life-saving, unquestionable. And for many women, especially younger and middle-aged women, that message has been supported by large clinical trials showing that screening can reduce deaths from breast cancer. But there is a critical detail that rarely makes it into public conversation, and that detail matters deeply once a woman reaches her mid-70s. Women over the age of 75 were never included in the major mammography trials that shaped modern screening guidelines, which means that while we confidently say screening helps younger women, we cannot honestly say the same thing for women in their late 70s, 80s, and beyond, because the evidence simply does not exist. And in medicine, the absence of evidence is not the same as evidence of benefit. What this means is not that mammograms are harmful by default after 75, but that the decision to continue screening enters a very different category, one that requires nuance, context, and an honest discussion of trade-offs rather than blanket reassurance. As women age, their bodies change, their health priorities shift, and the balance between potential benefit and potential harm becomes far more delicate. Yet many women continue annual mammograms out of habit, fear, or the belief that stopping screening is somehow irresponsible, when in reality, continuing without reflection may expose them to risks that are rarely discussed. One of the most common of these risks is false positives, which occur when a mammogram detects something that looks suspicious but turns out not to be cancer. And false positives are not rare events. They become more common with age, meaning that older women are increasingly likely to be called back for additional imaging, biopsies, and follow-up appointments that ultimately reveal nothing dangerous. But the emotional toll of that process is real. Anxiety does not disappear just because a test result turns out to be benign. The days or weeks spent waiting, imagining worst-case scenarios, replaying conversations, and questioning one's future can leave a lasting psychological imprint, especially for women who have already lived through illness, loss, or medical trauma. And then there is overdiagnosis, a concept that sounds abstract until it becomes personal. Overdiagnosis refers to the detection of cancers that would never have caused symptoms, suffering, or death during a woman's natural lifespan. And this phenomenon increases sharply with age because many breast cancers grow so slowly that they will never become clinically relevant in an older body. In fact, research suggests that nearly half of breast cancers detected by screening after the age of 75 fall into this category. Cancers that, left undiscovered, would never have harmed the woman in any meaningful way. Yet once a cancer is labeled, it sets off a cascade. More tests, more procedures, and often treatments like surgery, radiation, or hormonal therapy, each carrying its own risks, side effects, and burdens, none of which are trivial in an aging body. Treatments that may be well tolerated at 50 can be profoundly disruptive at 80, affecting mobility, independence, cognitive function, and overall quality of life. This is why the conversation around mammography after 75 cannot be reduced to a slogan or a checkbox on a medical form. It requires an individualized approach that considers a woman's overall health, life expectancy, personal values, and tolerance for uncertainty. This perspective is reflected in the guidance from the American Cancer Society, which does not issue a blanket recommendation for or against screening in older women, but instead emphasizes shared decision-making, encouraging women and their clinicians to weigh the potential benefits and harms in the context of the woman's broader health picture. A woman who is 78, active, and managing few chronic conditions may reasonably choose differently from a woman of the same age who is coping with advanced heart disease, frailty, or cognitive decline, and neither choice is inherently right or wrong. What is problematic is when women are never told that they have a choice at all, when screening continues by default, driven more by inertia and fear than by evidence. Fear is a powerful force in medicine. It can push people toward action even when action may not improve outcomes, and breast cancer fear is particularly potent because of its cultural visibility and emotional weight. Many women worry that stopping mammograms means giving up, being negligent, or inviting disease. Yet the reality is that choosing not to screen can be an active, thoughtful decision grounded in self-knowledge and realism rather than avoidance. It can mean prioritizing comfort over intervention, peace of mind over constant vigilance, and quality of life over the pursuit of every possible diagnosis. It can also mean acknowledging that no screening test can offer certainty, and that more testing does not always equate to better health. Importantly, this conversation is not about denying care or dismissing cancer risk. It is about aligning medical care with what actually matters to the individual woman at this stage of her life. Some women value early detection above all else and are willing to accept the risks of false positives and overdiagnosis, while others value minimizing medical machethilstva, preserving independence, and avoiding unnecessary stress. Both perspectives are valid, but they require honest information to be meaningful choices. Unfortunately, the healthcare system is not always designed to facilitate these nuanced discussions. Time constraints, performance metrics, and deeply ingrained screening culture can all conspire to keep the default setting on continue, even when the evidence grows thinner. This is why it is so important for women and their families to feel empowered to ask questions, to request conversations about goals of care, and to challenge the assumption that more screening is always better. Aging is not a failure of medicine. It is a natural process, and good medical care in later life looks different from care earlier on. It is less about chasing every possible abnormality and more about supporting function, dignity, and well-being. When we acknowledge that the major mammography trials never included women over 75, we are not undermining science. We are respecting its limits. When we talk openly about false positives, anxiety, and overdiagnosis, we are not discouraging care. We are making it more humane. And when we emphasize individualized decisions based on health rather than fear, we are honoring women's autonomy rather than reducing them to statistics. So the next time the reminder letter arrives, or the appointment is automatically scheduled, pause. Not to panic, not to comply reflexively, but to ask a deeper question. At this point in my life, what does taking care of myself really mean? Because the most important screening tool after 75 isn't a machine. It's an honest conversation, and the bravest choice a woman can make is not always to do more, but to decide, thoughtfully and confidently, what truly serves her now. Prostate-specific antigen testing, or PSA testing, is often framed as a simple blood test that saves lives, but the reality is far more complicated, and in many cases, far more harmful than most men are ever told. PSA testing does not just detect aggressive, life-threatening prostate cancer. It also detects slow-growing, low-risk cancers that would never cause symptoms, never spread, and never shorten a man's life. Autopsy studies have shown that nearly half of men over the age of 70 have prostate cancer cells in their prostate, yet the vast majority of them never knew it, never suffered from it, and never died because of it. These cancers existed quietly, doing no harm, while the men lived full lives and died of completely unrelated causes like heart disease or stroke. The problem begins when a PSA number comes back elevated. That single number, often discovered during routine screening, sets off a chain reaction that is difficult to stop. Elevated PSA leads to biopsies. Biopsies lead to diagnoses, and diagnoses lead to treatments that can permanently change a man's quality of life. Prostate biopsies are not benign procedures. They involve inserting needles through the rectal wall into the prostate, carrying risks of pain, bleeding, infection, and in some cases life-threatening sepsis. Once cancer is found, even if it is slow-growing and unlikely to ever matter, the word cancer exerts enormous psychological pressure. Many men feel they must act immediately, even when evidence shows that observation would be safer. Surgery to remove the prostate, known as prostatectomy, and radiation therapy are common next steps, and while they can be life-saving for aggressive disease, they come with significant and often permanent side effects. Urinary incontinence can leave men dependent on pads or catheters, affecting dignity and daily functioning. Erectile dysfunction can profoundly alter intimate relationships and self-identity. Bowel problems, fatigue, and chronic pain may follow. And for many men, especially older men, these harms occur without any meaningful extension of life. Large randomized trials have shown that for men over 70, PSA screening offers little to no survival benefit, yet exposes them to substantial risks. That is why the U.S. Preventive Services Task Force recommends against routine PSA screening after age 70 and urges careful, individualized decision-making even before that age. This recommendation is not about denying care or ignoring cancer. It is about recognizing that more testing is not always better medicine, and that finding disease does not automatically mean saving lives. It is about understanding that medicine must balance benefits against harms, especially in older adults who may never experience symptoms from the cancers we detect. Too often, PSA screening is presented as a moral obligation, a test every responsible man should get, without honest discussion of false positives, overdiagnosis, overtreatment, and the lifelong consequences that can follow. True informed consent means telling men that an abnormal PSA does not necessarily mean dangerous cancer, that many prostate cancers grow so slowly they will never matter, and that treatment can sometimes do more harm than the disease itself. It means acknowledging uncertainty, respecting patient values, and recognizing that living longer is not the same as living better. And perhaps the most uncomfortable truth of all is this: when we screen aggressively for prostate cancer in older men, we may be treating numbers instead of people, diseases instead of lives, and fear instead of facts. So before the next blood test is ordered, before the next biopsy needle is inserted, before the next surgery changes a life forever, we must ask a harder question. Are we truly preventing death, or are we creating patients who never needed to exist? And here is the hook that matters most. If a cancer would never have harmed you, but the treatment does, was finding it really a victory? Or was it a mistake we need the courage to rethink? Most back pain improves on its own. That statement alone sounds almost unbelievable in a world where pain feels urgent, threatening, and deeply personal. When your back hurts, it doesn't feel like something that will simply pass. It feels structural. It feels permanent. It feels like damage. And because it feels that way, we go searching for answers as fast as possible. We book appointments. We demand scans. We want proof. We want certainty. We want someone to point to an image and say, "This is the problem." But what if the story we've been told about back pain, the story that makes us afraid, is the very thing that keeps us stuck? For decades, we've been conditioned to believe that pain equals damage, that if something hurts, something must be broken, and if something is broken, it must be fixed, preferably quickly, preferably surgically. But the human body doesn't work like a machine with replaceable parts. Pain is not always a reliable indicator of injury. In fact, pain is often a poor narrator of what's actually happening inside the body. Especially when it comes to the spine, here's the part that almost no one tells you early on. MRI scans almost always show something, even in people who feel perfectly fine. Disc bulges, disc degeneration, herniations, facet joint changes, wear and tear. These findings sound alarming, especially when written in bold letters on a radiology report. But here's the truth. These changes are incredibly common. They are part of normal aging. They are found in people with no pain, no limitations, and no history of back problems at all. By the age of 30, a significant percentage of people will already show disc bulges on an MRI without any symptoms. By 40, that number increases dramatically. By 60, degenerative changes are almost universal. Yet most of these people are walking, working, exercising, and living their lives without thinking twice about their spines. The scan didn't create pain. The pain didn't require a scan. But once the image exists, the story changes. That something on the scan creates fear. Fear changes how we interpret sensations. Fear makes us hyper-aware of every twinge. Fear turns discomfort into danger. And once fear enters the picture, pain behaves differently. Muscles tense. Movement becomes guarded. The nervous system stays on high alert. The brain starts scanning for threat instead of safety. Pain becomes louder, more persistent, and more convincing. Not because the body is worsening, but because the system is stuck in protection mode. And fear doesn't just change how pain feels. It changes decisions. It changes conversations in exam rooms. It changes the path people are sent down. Once a scan shows abnormalities, the focus shifts from recovery to correction, from reassurance to intervention, from patience to urgency. And that's where the real problem begins. Early imaging makes surgery 12 times more likely, not more effective. Let that sink in. 12 times more likely. Not because surgery suddenly becomes necessary. Not because outcomes improve. but because once something is seen, it feels irresponsible not to act on it, both for patients and providers. The image creates a pressure to do something, even when the best thing might be to do less. Surgery, like imaging, has a powerful psychological effect. It validates pain. It gives it a concrete explanation. It promises resolution. But for many people with back pain, surgery doesn't address the root cause, because the root cause was never structural damage in the first place. And when surgery doesn't work, or only partially works, the disappointment can be devastating. Pain feels more permanent. Fear deepens. Trust in the body erodes even further. None of this is to say that imaging or surgery is never appropriate. There are clear red flags where scans are essential: trauma, infection, cancer, progressive neurological loss. But those cases are rare. The vast majority of back pain is classified as nonspecific, meaning there is no single identifiable structure responsible for the pain. And nonspecific does not mean mysterious or hopeless. It means the body is experiencing a complex interaction of movement, stress, loading, sensitivity, and perception, all of which are adaptable and reversible. The spine is not fragile. It is one of the strongest, most resilient structures in the human body. It is designed to bend, twist, compress, and carry load. Yet we treat it like a stack of porcelain plates, one wrong move away from disaster. This belief alone fuels pain persistence. When people believe their spine is damaged, they move less. When they move less, tissues weaken. When tissues weaken, movement feels harder. And when movement feels harder, pain reinforces the belief that something is wrong. MRI findings don't predict pain. They don't predict recovery. They don't predict who will get better and who won't. But beliefs do. Expectations do. Fear does. The story we tell someone about their back matters more than the picture we show them. If the story is one of damage, degeneration, and inevitability, pain often sticks around. If the story is one of strength, adaptability, and recovery, outcomes improve, even when the scan looks exactly the same. Pain is real. Suffering is real. But the explanation matters. When we overemphasize imaging, we unintentionally teach people to distrust their bodies. We teach them that pain must be fixed from the outside. We teach them that rest is safer than movement. And we teach them that time alone won't help. Even though, for most back pain, time is one of the most powerful healers. The body has an extraordinary capacity to heal. Discs reabsorb. Inflammation settles. Muscles adapt. The nervous system calms. But healing doesn't happen when fear dominates the process. It happens when people feel safe to move, safe to load, and safe to trust their bodies again. And that safety doesn't come from an MRI report. It comes from education, reassurance, and gradual exposure to movement. Early imaging often interrupts this natural recovery process. It medicalizes something that is often temporary. It labels normal age-related changes as pathology. And once a label exists, it's hard to unsee it. Every flare-up becomes proof that the scan was right. Every good day feels fragile. And the cycle continues. There is a difference between knowing what's happening and fearing what's happening. Imaging often provides information without context. And information without context can be harmful. When people understand that their spine is strong, that pain does not equal damage, and that movement is medicine, recovery becomes more likely. Not instantly, not magically, but gradually, sustainably, and without unnecessary intervention. We don't need fewer scans because scans are bad. We need fewer scans because they are often unnecessary, and because they change the story in ways that don't help. The goal isn't to ignore pain. The goal is to respond to it wisely, to recognize when reassurance is more powerful than investigation, when movement is more effective than rest, and when time is more therapeutic than surgery. Back pain is common. Almost everyone will experience it at some point, and most people will recover, regardless of what an MRI shows. The tragedy is not that people get back pain. The tragedy is that so many are taught to fear it. And fear is the one thing that pain thrives on. So the next time someone tells you that your scan explains everything, pause. Ask what it means functionally. Ask how common those findings are in people without pain. Ask whether the image changes what you can do today. Because seeing something doesn't always mean fixing something. And fixing something doesn't always mean cutting something. Your spine is not broken. Your body is not failing. Pain is not a life sentence. And the most important part of recovery often has nothing to do with what shows up on a screen, and everything to do with the story you believe about your body. Because here's the final truth that rarely gets said out loud. When we stop treating back pain like a structural emergency, people recover faster, with less fear, fewer surgeries, and better long-term outcomes. And the real question isn't, what did the MRI show? The real question is, what story did it make you believe? And is that story actually helping you heal? Whole body scans are often marketed with a simple promise: peace of mind. One scan, one visit, one machine, and suddenly, you're supposed to feel safe, reassured, protected from the unknown. It sounds responsible. It sounds proactive. It sounds like taking control of your health. But for many people, especially healthy seniors, the reality is very different. Instead of peace of mind, whole body scans frequently deliver something else entirely: anxiety, confusion, and a cascade of medical follow-ups that were never needed in the first place. This is not because doctors are careless. It's not because technology is bad. It's because the human body is full of variations, and modern scanners are incredibly good at finding them. When you scan everything, you will almost always find something. Studies show that incidental findings appear in up to 30% of whole body scans. These are unexpected abnormalities, spots, nodules, cysts, shadows, discovered in people who had no symptoms and felt perfectly well. Most of these findings are harmless. Many have been there for years. Some were present from birth. But once they're seen, they can't be unseen. And once they're written in a report, they demand attention. That is where the anxiety begins. Because the scan doesn't say, "This is nothing." It says, "Indeterminate, unclear significance, recommend follow-up." And suddenly, a healthy person becomes a patient. A follow-up scan is ordered. Then another. Maybe a blood test. Maybe a biopsy. Each step adds stress, cost, and risk, even when the original finding was never dangerous. This is the hidden downside of whole-body scanning. Modern imaging is powerful, but power without context creates problems. In younger people, this process already causes harm. In older adults, the risk multiplies. As we age, our bodies naturally change. Small lung nodules become common. Benign kidney cysts appear. Thyroid nodules increase. Calcium builds up in blood vessels. Degenerative changes show up in the spine. These are not diseases. They are part of normal aging. But a scan does not know your story. It does not know what matters to you. It does not know what will ever cause harm. It only knows how to detect differences. And the more detailed the scan, the more differences it finds. This is why no major medical organization recommends whole-body scans for healthy seniors. Not because they don't care about prevention, but because the evidence shows that these scans do not improve outcomes and often make things worse. Organizations like the U.S. Preventive Services Task Force, the American College of Radiology, and the American College of Physicians consistently advise against routine imaging in people without symptoms. Their reasoning is simple and grounded in decades of research. Early detection only helps when three things are true. First, the disease must be dangerous if left untreated. Second, the test must accurately identify meaningful disease. Third, early treatment must improve survival or quality of life. Whole body scans fail this test for most healthy people. They detect far more harmless abnormalities than life-threatening disease. And once detected, those harmless findings often lead to invasive procedures that carry real risks. A biopsy can cause bleeding. Surgery can cause infection. Sedation can cause falls or confusion. Repeated radiation exposure increases long-term cancer risk. None of this is theoretical. These are documented, measurable harms. Yet the marketing rarely mentions them. Instead, advertisements focus on fear. What if there's something growing inside you right now? What if you could have caught it earlier? What if this scan saves your life? Fear is powerful, but fear is not the same as evidence. The truth is that most cancers that matter eventually cause symptoms. And when symptoms appear, targeted testing is far more effective than scanning everything blindly. The idea that more testing always equals better care feels intuitive, but medicine has repeatedly shown that this is not true. In fact, overtesting is now recognized as one of the biggest threats to patient safety. This is especially true for older adults. As life expectancy changes, the balance between benefit and harm shifts. Finding a slow-growing cancer in a 30-year-old may matter, Finding the same cancer in an 80-year-old often does not. Many cancers grow so slowly that they will never cause harm within a person's natural lifespan. But once discovered, they are rarely left alone. Because psychologically, doing nothing feels harder than doing something, even when doing nothing is the safer choice. This is how overdiagnosis happens. Overdiagnosis does not mean a test was wrong. It means the disease found would never have caused problems. And whole-body scans are a perfect engine for overdiagnosis. They are not guided by symptoms. They are not guided by risk. They are guided by technology. And technology, when untethered from judgment, creates noise. For many people, the first sign of trouble is not physical. It's emotional. Sleep becomes difficult. Every ache feels suspicious. Every sensation feels amplified. A person who once felt healthy now lives under a cloud of uncertainty, all because of something that was never dangerous to begin with. This is not peace of mind. This is medical anxiety, manufactured by excess information. Good medicine is not about finding everything. It's about finding what matters. This is why evidence-based screening focuses on specific tests for specific people at specific times. Blood pressure checks, diabetes screening, colon cancer screening until a certain age, vaccinations, lifestyle counseling. These interventions have proven benefit. Whole body scans do not. They shortcut the thinking process and replace it with imaging. And imaging, without a clear question, rarely gives a clear answer. Doctors are trained to start with symptoms, history, and risk, not machines. Because the human body is not a puzzle to be solved all at once. It's a system that changes over time. And aging is not a disease. The promise of a single scan that checks everything is seductive, but misleading. There is no such thing as a test that finds only the dangerous things. Every test has trade-offs. Every finding has consequences. And once you step onto the treadmill of follow-ups, it is very hard to step off. This is why many physicians quietly discourage whole-body scans, even when patients request them. Not because they are hiding information, but because they understand the downstream harm. The real goal of medicine is not to eliminate uncertainty. It is to maximize meaningful health while minimizing unnecessary suffering. Sometimes, the most responsible choice is not to look, especially when you feel well, especially when the evidence tells us that looking won't help, especially when the cost of false alarms is high. Peace of mind does not come from scanning everything. It comes from understanding what truly matters and letting go of what doesn't. It comes from movement, connection, purpose, sleep, nutrition, and trust. It comes from doctors who listen, not machines that search blindly. And it comes from resisting the idea that more information is always better. Because sometimes, the most dangerous thing a test can find is fear.